Welcome to Advancing Health. In today's podcast, we learn how West Virginia University Medicine involves the entire clinical team, primary care physicians, virtual social workers, and others, to get children and young people the care they need before a psychiatrist is required.
My name is Jordan Steiger, and I am a Senior Program Manager for Clinical Affairs and Workforce at AHA. I'm really excited to be joined today by Dr. Adrienne Coopey from West Virginia University Medicine. Dr. Coopey is a child and adolescent psychiatrist who is extremely passionate about integrating physical and behavioral health services, which is, we know, something we love to talk about at AHA. And she is especially interested in doing this in areas of West Virginia where children and their families face challenges in accessing behavioral health services. She and her team are doing lots of great work, not only to improve the outcomes for these children and their families, but also really trying to support the healthcare workforce and clinicians who are developing behavioral health programs and delivering services, maybe for whom behavioral health is not their specialty area. So, Dr. Coopey, thank you so much for being with us today.
Thank you.
So, to get us started, please tell us just a little bit about you and your role at WVU.
Thank you, Jordan, for that lovely introduction. I think the biggest thing is I'm really fortunate to have the support of West Virginia University to do this work because I really enjoy it. And it doesn't always pay well, right? Reimbursement can be an issue. So I am currently a fully virtual faculty member in the Department of Behavioral Medicine and Psychiatry. And my role there at WVU is primarily in teaching psychiatry residents and the child and adolescent psychiatry fellows so they can join the workforce and help take care of our people. So teaching is a big role in my work, and it has been all along, which I didn't really catch on to. But through integrated behavioral health, I've really done a lot of teaching all along. I think most of my early career has been inpatient child and adolescent psychiatry, emergency departments, doing consult liaison work in medicine and pediatrics. And then the integrated behavioral health work was just kind of like natural development. It kind of happened. There's this medical overlap, behavioral health in a lot of the work that I was doing. And I got really lucky. The hospital that I was working in supported me to implement integrated behavioral health into primary care. Now I've been at WVU for 2 years, and really I was hired to implement behavioral health integration.
I love that WVU has made this investment in behavioral health integration. I think that speaks so much to the system and the priorities. And I love that you are completely virtual. I know we'll talk about that a little bit more later and how that helps you in your role. But I'd like to go back to, you are a child and adolescent psychiatrist. You've practiced for a long time in this role. I know you're really passionate about the care that you provide. We know that there are not enough of you out there in the workforce right now. There are just not enough people going into psychiatry, and especially child and adolescent psychiatry. What does this mean for patients? What does this mean for the short-term and long-term outcomes for these kids when they can't see a psychiatrist?
Right. So all of that is true. We are not able to produce enough child and adolescent psychiatrists to see every kid who needs help. But I would argue we don't need to. Our primary care providers are really seeing the kids who need behavioral health intervention. They're seeing them first, right? They're identifying their needs pretty early, right? We have made it important for screening tools to be implemented for depression and anxiety. So our primary care providers are seeing these kids right off the bat. If we can support our primary care providers to intervene early, we may not need as many child psychiatrists as we feel we do at this point. Treating behavioral health, though, is so different than, say, treating strep throat, right? We don't have that one test that gives us that one answer and know that one antibiotic is going to be helpful. And so that can make it a little more difficult to just do. And that is where I get to be a part of sort of distilling all that I've learned to support the primary care providers.
So, what I'm hearing you say, I think, is that we need to maybe shift our mindset around this a little bit. Not every child needs to be seeing a psychiatrist, and that early intervention piece is really important. And I know that that's something that WVU Medicine is really investing a lot of time and resources in right now. So, could you tell us a little bit about the work you're doing to empower that early intervention and get kids the care that they need?
Yes, we have implemented three different programs already in behavioral health integration that has been very exciting for me. One that I have continued today, and it is a direct education with a primary care provider. I have a pediatrician that I work with in an area of West Virginia that has no behavioral health services as far as child and adolescent psychiatry is concerned. She primarily sees children with behavioral health needs, and I talk to her a couple times a week about patients, and we help implement those screening tools in a way that makes it easier for her to care for kids. I give her recommendations, but really she's doing all the work. And often I am just saying, yeah, that sounds like a really good idea. And that has gotten a lot of children seen earlier and getting the care in their communities that they would otherwise have to travel pretty far for. Another program is primarily supported through our population health department. Really cool. It is a fully virtual collaborative care model. In general, the collaborative care model parks a social worker in a primary care office who then is the liaison between the patient, the primary care provider, and the specialist, the child and adolescent psychiatrist. I've worked in that model. It's super fun. It's great to have that collaboration with everybody in that team model. This model is completely virtual. The primary care provider can be in any setting. The social worker is calling the patient using the medical record to communicate, and I have direct conversations with the social worker. What that gives us is an opportunity to see patients in various practices that could be geographically quite separated. That was one of the difficulties with rural collaborative care, is that the social worker may not have enough volume in one practice to really support their position. And so this really negates that issue. The third thing that we're doing that's super fun is we call it e-consultation. It is an interprofessional consultation. So the primary care provider puts in an order and a question about a patient. It comes to me or one of our child psychiatrists electronically. We review the chart, review the question, and send back an answer. These can be really great because we can give it an answer pretty quickly, and we can bill for it so it can support itself. The primary care provider and this child psychiatrist are part of any kind of billing and RVU generation. So that can be helpful in supporting the program. That can give those patients who may not be appropriate for a collaborative care model a more immediate answer before they can get to a child psychiatrist in specialty care.
Wow, so many things you've mentioned I would love to just dive deeper and deeper into. I think that, I mean, the thread I hear among all of these programs, though, is the willingness to embrace that virtual care and the willingness to connect across a very large state with a lot of rural communities. I think being a big anchor system in a state like West Virginia, there is such an opportunity maybe for other, states similar to West Virginia to kind of model off of the work that you are doing. One of the things you mentioned at the beginning, talking about your different implementations is, how you work one on one with this primary care physician in a rural community in West Virginia. I love this. I think this is such a smart way to just spread that knowledge and help, like you said, just bring that access to care to communities where it wouldn't maybe be. You alluded to this at the beginning too, but we know that behavioral health provision, for services is a little different sometimes than primary care. So, how can other child and adolescent psychiatrists model kind of the work that you're doing and empower other primary care clinicians to be more confident in treating children with behavioral health needs?
Great question. And this has taken time to develop for myself. Getting little bits of information about someone and formulating a diagnosis and plan can be really difficult and a little scary. So, learning the ways that primary care providers can communicate with you in the same language. So, sometimes our primary care providers and our psychiatrists are speaking different languages. One way that we can speak the same language and get the same information is by using screening tools. And we are using screening tools in primary care a lot, right? We're using the PHQ, we're using the GAD-7 and the SCARED for anxiety, we're using the Vanderbilt for ADHD. We're doing that. And that can be a great way to get the information that you need and communicate it with each other, primary care and psychiatry, and follow the care. So we can use those to help support diagnosis. We can use those to help follow the care and see if we're getting better. Because one thing about psychiatry in general is that our responses aren't always immediate and they're not big. You don't go from sore throat to no sore throat, right? You have incremental improvements.
Absolutely, and just making it objective, like you said, it's not like you have sore throat and no sore throat. It could be a lot of time, a lot of different interventions, a lot of different experimentation with lots of different things to get that person to that right care plan, in psychiatry. So I think that that's a great takeaway message for our listeners is just figuring out what is that shared language and how can we come to kind of the middle and understanding each other between psychiatry and primary care. So I love that. As we start to close, what advice would you have for other health systems who are looking to integrate behavioral health into their other models of care?
Support it. I'm super grateful to WVU for for supporting my work. I am grateful to other hospitals that I've worked at for supporting behavioral health integration. It doesn't always pay up front, but the improvements on the end in quality of life, hospital visits, hospitalizations, and other needs are significant. So that prevention piece is really powerful.
I absolutely agree. Thank you so much. Is there anything else you'd like to add?
Thank you for having me. I really appreciate this. It is something I've been doing in the background for quite some time. And I know that individually, each primary care provider I work with is grateful. Their patients are getting what they need, and they are also grateful for this program. But I don't always get to talk about it big because behavioral health can be something that we don't talk about a lot. So I really appreciate that you've given us this time and spotlight to do it.
We are so happy to do so. I love talking about behavioral health and getting to help other people share their stories. So we are really excited to keep following your work and see what comes next.
Thank you.
Thanks for listening to Advancing Health. Please subscribe and rate us 5 stars on Apple Podcasts, Spotify, or wherever you get your podcasts.